Good morning again, Larry Martin here. I may have the chapter numbers wrong on this, but the subject is correct. The pediatrics, the lifespan development, and the kids with special needs. We've talked about the kids with special needs just a little bit, but one thing to notice here, I know we have not had trauma yet, but when we get to trauma and we get to doing your psychomotor skills, this is a device that we'll use called a Kendrick extrication device or a shortboard. This is usually used for adults to extricate them from a vehicle to where it makes it easier for us to secure them onto a long backboard. But notice that this guy here is using it as a full backboard for this smaller child. So a lot of times you have to think outside the box, and you've got a lot of equipment on your ambulance at your disposal, but sometimes you can use it for different things than what it was originally designed for. All right, so birth to one are considered newborns or infants. Actually, birth to 1 month is considered a neonate. The kids 1 to 3, those are considered toddlers, 3 to 6 preschoolers, 6 to 12 school age, and 12 to 18 adolescents. So what are some developmental characteristics of infants and children? They are not just small adults. They have a lot of different type of anatomy, physiology. They have different types of disease processes than do the adults. So here we have a newborn or an infant. They don't really tolerate being separated from the ones that they know. They don't, however, they don't really know strangers yet, so you don't see a whole lot of anxiety amongst these kids when there are strangers around. They're fine with you undressing them, however, obviously they would want to stay warm, so if you have to undress them, take the clothing away or pull it apart, whatever, look and see what you're needing to see, and then close the clothing back up. They should be able to track you visually, so that's one way that you can determine the orientation or the alertness of a infant is if they're tracking you across the room or tracking mom or they're turning away from you to mom, then they're pretty alert. They don't tolerate oxygen masks very well, so we do what's called blow-by oxygen. You'll just take your non-rebreather and lay it to the side of the patient's face, or even better, have mom hold it next to the patient's face, and it's blowing by the nose. And you can over-oxygenate an infant or a newborn, and it can cause some blindness. So blow-by oxygen is typically the way we go with infants. All right, so your toddlers, these are considered the terrible twos. If you have one at home, I do feel sorry for you. I'm thinking about you every day. They don't tolerate parental separation, and they don't really like to be touched except by, again, mom and dad. They may think that if they're ill or if they're injured, then that was a punishment for something that they may have done. They don't really too much like their clothing removed. They're very easily frightened, and they a lot of times overreact to things. They tend to be very perceptive. They're understanding things more than they want you to think that they're understanding things. And this is the time that they tend to start wanting to become independent. They don't want to hold your hand anymore when they cross the street, and of course that gets them in trouble. They want to do things on their own. Probably their most popular word at this time in their life is no. A lot of them are very possessive too. When they have toys that someone else is wanting to use, they get very possessive with them, and tend to get a little upset when somebody else is playing with their toys. They don't tolerate masks as well, so the blow-by oxygen is the order of the day for them as well. Now we got the preschoolers. They don't tolerate parental separation as well. They don't like to be touched. Now, instead of their modesty, they're starting to grow up, and they certainly have not reached puberty yet, but Be sensitive to their modesty. They too may think that an illness is some type of punishment for something they've done. They don't like blood. They don't like pain. They tend to over exaggerate pain. Remember, these people are not the best of historians. If you ask this young lady here, how long have you been sick? She may say for 2 years. Well, it's only been 2 days or 2 hours. So they're not the best of historians. With these and with the toddlers, if you can get something that they would enjoy while you're doing your assessment, like a toy, or if you guys carry bears on your ambulance or stuffed animals, and you can certainly give them one of those to try to get them in favor with you. They're very curious. They tend to communicate well, but again, you kind of have to sometimes take with a grain of salt the answers that they're giving you. They tend to be a lot more cooperative than the toddlers do, and they don't tolerate mess, so blow-by is going to be the way to go. Now we're getting into school-age kids. These kids tend to be pretty cooperative, but they expect that whatever they've got to say, they want people to listen. Some of these kids at this age are going through puberty, so you need to really make sure that you are sensitive to their modesty. Just like the age before them, they're real concerned about blood and permanent injury, disfigurement. As you're examining them, especially if they're up around the 10 to 12 age, make sure you explain to them what you're doing upon your examination. They should be able to, if you put it in words they can understand, they should be able to understand what you're doing and why you're doing it. Be calm with these kids. Having mom or dad in the room on all these kids are probably going to help you, other than when we get to the adolescents. And make sure that you respect the kids' modesty. So these kids, 12 to 18, are the adolescents. They want to be treated as adults, and if they want to be treated as adults, then they should act as adults. So sometimes they have the same characteristics as the toddlers do. They're just a little bit older with that. They think that they're 10 feet tall and bulletproof. Your toddler, he may run over somebody's foot with a big wheel, and okay, the foot got bruised, but these people are driving, 2.5-ton vehicles at 60 miles an hour. They're just learning to drive. They're probably not the best drivers out there. They're experimenting with drugs and alcohol and other things. This is a really tough time for kids, whether they think it is or not. This is a really tough time in growing up. They also fear that whatever injury they may have, it could disfigure them for the rest of their life. So there's a lot of different emotional and physical development that, some kids develop very well physically and emotionally. Some of them never develop emotionally. They may develop physically okay, but, they always have some type of emotional issue, even up through adulthood. So let's look at some anatomical differences in kiddos versus adults. So you notice that this kid's head is a lot larger in relationship to the body than what the adult's is. So it's larger, it's heavier, it's softer. Infants and small children especially have got the real disproportionate heads. You see that when you lay them supine like this, their neck flexes. And when it flexes like that, then it's occluding the airway. So what you would want to do is you would want to put a towel or some type of padding under the shoulders like you see here, and that gets that child's airway in line. The fontanelles are the soft spots in the infant's skull. This is so as the child starts to grow, the brain can grow inside before the bones of the skull are actually sutured together and become one large bone with just suture lines in it. These will exist until they're about 1 to 18 months old. If you have a child who you notice the fontanelles are sunken, then that could indicate that they are dehydrated. If you have a child who has got bulging fontanelles, this could be a sign that they have some type of increased intracranial pressure. Probably one of the more common ones, I'm sad to say, is shaken baby syndrome. So make sure you keep an eye out for that. Now, when when infants do cry, especially when they're exhaling, their fontanelles will bulge, but then they go back down whenever they're inhaling, or when they quit crying, they certainly go down. So just look at those fontanelles, and that may tell you something. If they're sunken or if they're bulging, it may give you an idea about what might be going on with the child. The child's airway, they have a smaller nose and mouth than the adults. The tongue is larger in proportion to the size mouth than what the adults is. The trachea is narrower. You can look at an infant or a small child, and you can look at the pinky finger of that child, and that's the diameter of the smallest part of their airway. The smallest part of their airway is what's called the cricoid ring, and again, it's about the same diameter as their pinky finger. The airway structures are a lot more easily obstructed in the children than they are in the adults, whereas their smallest part is the cricoid ring. The smallest part of the adult is going to be at the glottic opening right here at the vocal cords. I wouldn't spend a whole lot of time memorizing these numbers. You should, have a pretty good idea about what's normal for, for any age kid. Like if you saw something, you got a 5-year-old that's breathing 60 times a minute, I would hope that you would know that that's way too fast. Same thing if you have any child breathing or any patient breathing, less than 10 to 12 per minute, and that would be too slow. Some more airway issues are differences. The infants are obligatory nose breathers, so they typically just breathe through their nose. It hasn't really dawned on them yet they can breathe through their mouth. So suctioning the nasopharynx with either your bulb syringe or with your soft suction flexible catheter can improve the breathing significantly. Put the kid's head in a neutral position. If you extend it too far, their trachea is not as rigid as the adults, and you can actually completely occlude the trachea by overextending the head. Kids compensate when they breathe faster, when they breathe deeper for a while, but they get worse a lot quicker, and they just give up. Whenever they decide, look, I can't do this anymore, boom, it just stops. The chest and abdomen are less developed, and their chest is a lot more elastic. So let's say that you've got a child that is restrained as they should be in their seat belt or their car seat, and they go chest into one of these restraint systems, then that chest is going to sink in quite a bit more than with the adult because of the elasticity of the chest. The intercostal muscles are not real fully developed yet, so you see a lot of diaphragmatic breathing with kiddos, and their abdominal organs are a lot less protected than the adults, so you probably are going to have a higher incidence of abdominal injuries in children versus adults. The pulse rates are going to differ. Typically, the younger they are, the faster the pulse rate is going to be, so infants can be up to 160 beats a minute or more. This is about all they have going for them whenever they want to compensate for decreased perfusion. They don't really have the ability to constrict vessels like the adults do, so the biggest thing they've got going for them is it increases the heart rate. So this will give you an idea about how much circulating blood volume that there is in different stages of your life. Here we have a 9-pound newborn. That's a pretty good sized newborn. This child has about 300, and that says 335. A Coke actually is 355. So just think about a can of Coke. That's all the circulating blood volume that newborn has got. So they can't really stand to lose any blood, whether it be from trauma or even if you're delivering this baby and you cut the umbilical cord and they start to bleed from the baby's side, they can't really stand to lose any blood from that umbilical cord. Now you get up to a 60-pound kiddo. This kid has just about a liter of Coke or soft drink in as far as the blood volume, and then you get up to 125 pound, you have about 2 liters right here or I'm sorry, 2 liter. So that's about 4 liters. Of course, if she was a little bit heavier than that, she probably would have a little bit more blood volume. All right, the integumentary, or the skin, is larger in proportion to their body mass than the adults are. That's why they're one of the reasons they have a more increased risk for hypothermia. We talked during environmental emergencies about other reasons, like a 1-year-old can't get up and go get a coat out of the closet and put it on, and so forth. The burn injuries are calculated differently, guys. I wouldn't worry about excuse me. I wouldn't worry about this part until we get to trauma, when we start talking about burns, and then we'll talk about how to estimate burn calculations. All right, you look at this young lady, and a lot of times with kids, we look at them and from across the room, we can say that's a sick kid, or that's not really a sick kid. This kid looks pretty sick. Even though you take the thermometer out of her mouth, I think all of us would agree that this kid looks pretty sick. Make sure that when you are approaching an infant or child, remember they're not going to like you because you're a stranger, and that's not a bad thing. If they start to scream and cry as you get closer to them, that at least tells you that child is not too terribly sick. You need to make sure that you know the equipment that you have on your animals, because we do have equipment that satisfies almost every age group, whether it be a blood pressure cuff or whether it be something like a C-collar. Sometimes we have to fashion things out of towels or whatever, but for the most part, you do have age-appropriate equipment on your ambulance, and make sure you do an age-appropriate physical exam on them as well. Get the age, the gender of the child, the location of the scene. If it's a medical issue, what's the nature of illness? If it's trauma, what's the mechanism of injury? You're trying to get all this from dispatch. Make sure the scene is safe when you get there. Where is the patient? Is the patient by themselves? Is mom or dad holding the patient? Are there any safety threats that you have to be alert for? If it's a poisoning, just like with the adults, you need to try to bring the medication or the substance with you to the hospital. If it's a mechanism of injury or a nature of illness, you've got to try to gather information. Again, the younger they are, the poorer historians that they are. So maybe the family members might be a little bit better at giving you a history. Assume if it's an injury that it was significant enough that there may be head or neck injuries. And again, putting the C-collar on if you can find one to fit. If not, we typically will just take a towel and roll it around the child's neck and improvise and use that as a C-collar. This is what we call the pediatric assessment triangle, or the PAT. The A is for appearance, the B is for breathing, the work of breathing, and then the over here is the circulation to the skin. So it should take you no more than 30 seconds to look and see, address all of these and try to get a good idea of, like, does this kid look good? Okay, if he looks good, what kind of work of breathing? Well, his work of breathing is a little bit increased, but let's look at his skin next. Skin's pink, warm, and dry, so okay, he's probably more in respiratory distress than he is in respiratory failure. There's no equipment that's required other than your eyes to do the PAT. It doesn't really require you to touch the patient. So again, the appearance, the breathing, and the circulation, those are the three parts. So the appearance, we're noticing their level of consciousness. Again, if you've got a 2-year-old that's tracking your every move, that's a good alertness on that 2-year-old. If you've got a child whose eyes are shut, mom is holding a limp child, there's muscle tone comes in. There is no muscle tone. And then if this child is interacting or not. This is an acronym or mnemonic that some people use to help determine if the patient is sick or not. It's the Tickles mnemonic, tone. Again, this is what kind of muscle tone do they have? Are they limp? Are they moving their extremities? How interactive are they? Again, they may not be interactive with you, and that's okay, but if they're somewhat interactive with the ones that they know, then that's a good sign. Are they able to be consoled by mom or dad? Obviously not you. Their look or their gaze, some kids will just stare off into the future. Other kids will just, again, track you across the room, and that's the good part of it. And then their speech or cry, you can typically tell when kids are crying just to be crying versus I'm a really scared cry or I'm a really injured cry, sick cry, something like that. Then you're going to look at the work of breathing. Does mom or the child tell you that their body temperature has been increased? That's not a bad thing for the work of breathing to increase if they have a fever. That's kind of one of the defense mechanisms that your body has, is to try to get rid of some of the heat by increasing the respiration. They may be tachypnic. You may hear, even from across the room, you may hear some abnormal airway noise like stridor or wheezes. You may see some retractions of intercostal muscles, the muscles above the sternum and the muscles above the clavicles. You may see them doing a lot more diaphragmatic breathing than normal. You may see them flaring their nostrils. If the skin is pale and the mucous membranes are pale as well, then they probably are in compensated shock. Mottling is where you have somewhat of a pale and red mixed together in just a mottled appearance. That's probably a sign that they have poor perfusion, and if they're blue or cyanotic, then most likely they have a decreased level of oxygen. So do we need to stay and play, or do we need to load and go with these kids? So if they're unstable, make sure you assess their ABCs, treat the life threats, and then transport immediately. If they're stable, then we can most likely stay on scene for a little while and do our assessment on scene. You probably will be scared of all these kids, whether they're stable or unstable, because you really don't make too many pediatric calls, and you're just not good at it because of the lack of exposure that you have to them. So, if you want to, if one of you is better than the other, if your partner's better with kids, let's say you're 40 years old, you've never had children, your partner's 30 years old and has 5 kids at home, then he might be the one to do the assessment part of these children. All right, so we look at this little guy. He looks pretty happy. He's eyeballing the doctor there, and so I think all of us would pretty much agree from across the room that this kid is the one that we can stay on scene with, and he's not really sick. So if the airway's open and will remain open, then make sure that you assess for the respiratory adequacy. If the patient's unresponsive or they're having difficulty keeping the airway open, then make sure you open the airway by whatever means you see fit. Please, again, do not overextend that airway, because you can completely occlude the trachea if you overextend the airway. If there's anything that you can be cleared with suction, or if you can see a foreign body with your eyes and you can stick your fingers in there to remove it, or get your McGill forceps, then certainly you can do that. All right, listen. Can you hear audible respirations without a stethoscope, or do you have to get your stethoscope to hear these sounds? The crowing or the stridor, that's an upper airway issue from things like croup or epiglottitis. It could be a partial airway obstruction from a foreign body. It could be a partial airway obstruction from smoke inhalation. Whatever the underlying cause is, the crowing and the stridor is going to sound, you're going to hear that sound upon inspiration or inhalation. The wheezing is typically caused by bronchoconstriction. Typically you hear wheezing on exhalation, and it's typically a lower airway sound that you're going to hear. Seal bark, about the only thing that we equate that to is a kid with croup. And then the grunting, remember, grunting is their way of prolonging their expiration phase. They don't really know any other way to do it other rather than to grunt every time they exhale. Look, listen, and feel with the breathing. If you need to put your hands on the patient's chest to see if there's adequate chest rise involved, and certainly we can do that. And the infants are going to be belly breathers. Even some of the toddlers, especially in the early stages of toddlerism, they're still going to be belly breathers. Determine if the patient has a pulse. If they're bleeding, then obviously we'd stop it. If they don't have a pulse, then we would start CPR. Or, do we feel a carotid pulse only? We don't feel pulses anywhere else, then probably the child is in shock. With the infant, we typically check the brachial pulse. The femoral pulse can be very difficult to assess. First, you're probably going to have to take the diaper off if the child has a diaper on, and it's pretty hard to detect a femoral pulse. A lot easier to get a brachial pulse than a femoral. Kids older than 1, then we can do a carotid pulse. And so if you have strong central pulses, that's a pretty typically good indication that the child is not hypotensive. This is the Glasgow that has been modified for children. It's not a huge modification, but obviously less than a 1-year-old can't speak. So with the eye opening, if the eyes are open, then that's a good thing. They get a 4. If you please be careful about shouting at them. Don't just get right in their ear and go, hey. If they respond to that, it's a 3. If they respond to pain, a 2. If there's no response, 0. Now you look here, and this is where you see a lot of differences with the verbal. If they either babble or they coo appropriately, then that's a good thing. They get a 5 out of that. If they cry, but it's exaggerated, then again a 4. And you see all the way down here. I don't have to read this to you, so just look at this, and you can tell there's a few differences between the adults and the kiddos. It's still the best you can get is a 15. The worst you can get is going to be a 3. And then we need to expose. If you found something during the PAT that makes you think that you need to expose the patient, that part of the patient, then go ahead and do that, please. And again, make sure you avoid heat loss. If you need to look at something and open the clothing, look at it and put the clothing back unless you need it open for some reason. Now we got a transport decision. Immediate transport is indicated if they have a significant mechanism of injury, if the history that them or the family gives you is compatible with a serious illness, if there's a physiological abnormality noted, if there's a serious anatomic abnormality noted, if they're in significant pain, and kids are not the best at describing pain to you, so you're just going to have to take their word for it. And then if they have an abnormal level of consciousness. So your questions are based on the chief complaint. So what's their nature of illness or mechanism of injury? If it's how long have they been sick or injured? What were some of the events leading up to it? Was there a fever? If so, have you tried to do anything about the fever? Try to lower it with some Tylenol or Motrin or sponge bathing? How are they acting? You've never seen this kid before, so you heavily rely on family members or daycare workers to tell you this child is just not acting normal. What's the patient's activity level? And then have they been eating okay, drinking okay? Has their urine output been okay recently? You can do a full body scan, and when the patient's unresponsive and has a significant mechanism of injury, so make sure you're checking for the DCAP BTLS. If you need to do a focused assessment, then certainly, if a child cut his finger with something and all he has is a cut finger, then obviously that would be a focused assessment. You wouldn't have to do a head-to-toe on that child. Secondary assessment, we're going to assess the fontanelles. We're going to look at the nose. If any kind of congestion or mucus in there, then we may need to get our bulb syringe or a soft suction catheter and suction the nose. Kids do like to put things in their ears, so be aware that beans and so forth may be in their ears. Drainage from the ears may indicate that they have a skull fracture. If they have bruising behind the ears, that may indicate also that they have a skull fracture. That's called battle signs. And then there may be pus coming out of their ear, and if it's pus, then they probably have some type of ear infection. Look in the mouth. Is there any active bleeding? Do you smell anything coming out of the mouth? Are there any teeth that are loose? If they cannot move their neck and they have a high fever, then you need to be very, very aware that they probably have meningitis. You need to put a mask on you and this kid both to make sure you don't take it home to your family. Look at the chest, if there's any trauma, lacerations, bruises, rashes. Rashes also can indicate meningitis as well, but it can be other things like allergic reactions and so forth. Feel the clavicles, if they're tender, ribs, same thing, and then auscultate the lungs. Abdomen, look for distension. Now, some kids do have, little bellies on them, and that's typical. But if mom tells you, yeah, that belly's a lot bigger than normal, then that's going to be an issue. So if there's any tenderness or masses, look for seatbelt or child car seat marks on them as well if it's a car accident. Look at the pelvis, see if there's any bruising, see if there's any instability. Really, unless you have a child who is a victim of sexual abuse, we don't really get near the genitalia or perineum unless we have a really good reason to do that. Extremities, start at the top, go to the bottom. Again, do the DCAT BTLS. Make sure when you get to the bottom of each extremity that you're checking pulse, motor, and sensation in all the extremities. Vital signs, please make sure that you at least have an idea about what a normal pulse rate should be for your age groups. Blood pressures, a lot of medical directors really don't concern themselves too much with blood pressures with kids under the age of 3. They're really more concerned about a capillary refill than they are a blood pressure, but there actually is a formula that we can use to determine, there's no formula for respirations, there's no formula for pulse rates, but there actually is a formula for trying to determine what a normal blood pressure should be for any kiddo. As long as the blood pressure is at least 70 plus twice the kid's age, then they're okay. So if you got a 4-year-old, if they've got a blood pressure of at least 78, that's a good thing, okay? They're not hypotensive, we'll say that. What really is a normal blood pressure is 90 plus twice their age. So, again, for a 4-year-old, 98 is probably what would be normal for that child systolic. But as long as we have it at least 78 or above, then that's considered acceptable. All right. If you're going to get a respiratory rate, you can count it for 30 seconds and double the number. If you're not good at math, then by all means count it for seconds. Kids less than 3, you're probably better off looking at the belly and seeing what's the belly rise and fall to get the respiration rate. As with adults, if they're stable, we're going to check them every 15 minutes. If they're unstable, every 5 minutes. All right. We look at this kiddo right here. Again, looks pretty happy. Got a little smile on his or her face, looking at something, so not too terribly ill right here. Maintain an open airway. Make sure if they're in shock that you, again, keep them supine, cover them up, give them oxygen. If they do need oxygen, even if they're not in shock, then certainly we would provide that to them. And then if we need to support their ventilations, then support ventilations. All right, here we see this infant. If this towel or blanket was not underneath the shoulders, this child's head would be flexed. So make sure you get it to where it's in a neutral position, like you see here, that it's not overextended. Very seldom do we use the rigid suction catheters until they're at least school age. But make sure that you're using the appropriate size catheter whenever you are suctioning any child of any age. And try to suction as briefly as possible because, again, the younger they are, the more likely that they could go into a bradycardic rhythm due to you making them hypoxic because of your suctioning. So with the oral airways, you measure it just like you do with the adults. You're going to measure from the earlobe to the corner of the mouth. But unlike the adult, you're going to insert it tip down. The younger they are, the less developed they have with their hard palate, so you could actually cause some tissue damage. So try to get something to press the tongue down as you're introducing the oropharyngeal airway into the patient. Nasal airways, the same thing. We measure like you do with the adults from the earlobe to the nose, and make sure that you do not have any facial or head trauma when you're putting a nasal airway in. Signs of a partial mid-airway, or I'm sorry, a mild airway obstruction would be the stridor or the crowing, retractions on inspiration, so they're using those intercostal muscles to help them breathe. The skin's still pink, however, so they're moving some air. The capillary fill's under 2. They're still alert. They're not unconscious. So what do we do for these kiddos? Well, position of comfort. Mom's lap is okay. Blow by oxygen. The younger they are, the more likely you're going to do blow by oxygen. Transport, and try not to agitate the kids. So just like with the adults, if they're still moving air, there's really not a whole lot we do for them. However, if they have a full obstruction, then we're going to do 5 back blows with the infants. Make sure the head is lower than the body. Make sure you support the head, form a V around the mouth and the nose to keep the mouth open, so if something does come up, they can expel it that much easier. So we're going to do 5 back blows. You're going to turn the patient over, keeping the head down. You're going to do 5 chest thrusts. Now, I hope it makes common sense to you that if you do 2 back blows and something comes up and is laying on the ground, obviously we don't need to do the rest of it. But if after any of these, if you see something visible in the airway, you can remove it. We never blind sweep anybody anymore. With children, you're going to do the abdominal thrust until one of 2 things happens. It either comes up or they go unconscious. If it comes up, great. If it doesn't come up and they go unconscious, you need to start CPR. If you're going to ventilate a patient, make sure you use a proper size mask and bag. You should have 3 different size bags on your ambulance, one for the infants, one for pediatrics, and one for adults. If trauma is involved, then do the jaw thrust, not the head tilt, chin lift. And if you're unable to get a good seal with your mask with one hand, then use 2, and obviously you'd have to have someone else there to squeeze the bag for you. Children, birth to 1 year, 12 to 20 per minute. Same thing with your 1 to 8, 12 to 20 per minute. Kids over the age of 8, we're going to do 10 to 12 per minute. So again, if you have a brain fart when you're trying to ventilate any age child, the common denominator here is going to be 12. So 1 breath every 5 seconds will get you all 3 age groups of these kids. All right, here you see some of the more common causes over here of your hypoperfusion. This is real big with kids. These 2 lead to them getting this, especially if they're unable to feed properly like they're supposed to. Very seldom do we see the cardiac events or cardiac failure unless you've got a child that was born with some type of congenital heart defect. As we said earlier, the biggest thing they have going for them to compensate for shock is increasing the heart rate. I wouldn't quite pull on a child's scalp like this, but let's say that this person is pulling on this child's scalp like this and the scalp stays tinted like that, then that's a pretty good sign that there's poor perfusion. But kids, heart rates do increase during shock. The capillary fill will become and delayed, their mental status will start to decrease more so than what it normally is. Again, you're keeping them flat, keeping them warm, and giving them oxygen would be the thing to do. You hope that this scan snaps right back, and that's a pretty good sign that there's no shock involved at this point. With checking the circulation, make sure you get not only the rate, but also the quality of the pulses. See if the hands and feet, is everything warm other than the hands and the feet, and they may have some peripheral circulation issues. A capillary fill of less than 2 is normal. Look at the skin color. So here we have this little happy baby again. Again, you've already seen this. This is what you're going to do for someone who, for a child who is in shock. All right, let's talk about some common medical emergencies that you may see in kids. Respiratory illnesses are among the top 10 reasons for ER visits to kids under the age of 17. Asthma is the most common cause of respiratory emergencies in children. But also remember that trauma, there's other things like croup and epiglottitis, RSV that kids can get that can send them to the ER. So look for the nasal flaring, the grunting. Again, they're prolonging their exhalation phase by grunting. Do they have any abnormal sounds? Are they using their accessory muscles? Do you see retractions? And if the kid's old enough to realize that, hey, I can tripod and get my airway more in line, then you'll see tripoding in your older kids. So she probably could get a little bit more air moved and should sit up just a little bit more, but she's tolerating a mask okay, which is a good thing. If she was not tolerating that mask, then certainly you could do blow-by. So for the most part, with respiratory distress, we just use oxygen. However, if they're in respiratory failure, which remember, respiratory failure is not only an oxygenation problem, but a ventilation problem as well, then we're going to hook a BVM up to oxygen and ventilate the child. So when do we need to think about bagging a patient? Well, if the respiratory rate's less than 10 of any age group, if there's little or no muscle tone, they're unresponsive, they have a slow, absent pulse, make sure that you put an OPA in the patient, assuming that they will accept one, and then hook your bag valve mask up to oxygen, give them 100% oxygen. Now, this is something you'll carry on your ambulance. This is called a Broslow tape. And you start at the head right here, and then right down here you see at the heel of the foot, it's a light blue color. When you look at that light, it tells you how much the child should weigh, assuming that the child is of normal weight, they're not obese or whatever. It's going to tell you, like for paramedics, it tells them the drug dosages based on that weight. So you get a lot of good information by using that Broslow tape on kiddos. Obviously, if they're too long to use the Broslow tape, then you would use the adult type treatment. So don't ever let anybody tell you that asthma is not serious. People can die from asthma. So as we talked during respiratory emergencies, you got kind of a 1-2 punch of the bronchoconstriction and the mucus plugging the bronchioles. So wheezing as the patient starts to exhale because of the blockage in the bronchoconstriction. Sometimes it's completely blocked, and we have what's called a silent chest. They're trying to move air, but they're not even moving enough air to produce a wheeze. And as we've said, at least for the last 40 years, a silent chest is a deadly chest. Whatever position, most likely the tripoding or sitting up will be the position that they will want to be in to try to make the breathing a little bit easier. So you can give them oxygen if they have an MDI, or if they have a nebulizer, you can assist with those as well. If you need to assist the ventilations, then you can assist the ventilations with the BVM. We talked about status asthmaticus in respiratory, but just to readdress this, remember this is where you have a prolonged asthma attack that is not responding to traditional or conventional therapy. Guys, this is conventional therapy, your bronchodilator. So if they're not responding to this, then we have what we consider status asthmaticus. This can be deadly. Okay, croup and epiglottitis can sometimes look a little bit alike. One's viral, one is bacterial. Croup has got 5 letters, viral has got 5 letters. Epiglottitis has got a lot of letters, and bacterial's got a lot of letters. And that's how you can remember which one is viral and which one is bacterial. 6 months to age 4 years is your prime window for kids having croup. I've seen kids with croup playing video games. You walk into the house, you address the kid, he looks up at you and barks, and then goes back to playing his video game. So typically the croup will come about at night, usually in the wintertime when the heater in your home is drying the air out in your house. So these kids obviously are going to be in respiratory distress. So what do we want to do for these kids? Humidified oxygen is the best way to go, especially if you can cool it. So let's say that you do have a nebulizer on your ambulance. Again, you're not really supposed to. I mean, you can give albuterol to these kids, but let's say that you don't have albuterol, and the kid doesn't have any either. You can certainly put some saline in your nebulizer, and you can humidify the oxygen with just the saline instead of the albuterol being in the nebulizer. Again, cool air, which I know we don't have anything to cool oxygen off with, but cool, moist air is the best thing to help this kid. Now, it doesn't cure croup, all right, but it makes them breathe easier. So here we have epiglottitis. Again, this is bacterial because they both have lots of letters. Usually ages 3 to 7 are the age window that we see epiglottitis. If we could get every child in the United States immunized like they should be, then you probably would never see a case of epiglottitis. If you do have someone with epiglottitis, they're going to look sick. The croup kid may not look too sick, but this kid's going to look sick. They're most likely going to have a lot higher fever than what the croup kids are going to have. They're going to be drooling excessively because it hurts them too bad to swallow. They're probably going to be sitting straight up. So what do we do for these kids? We really don't do a whole lot for them, because if we do anything, it's going to agitate them. The agitation can cause the epiglottis to swell to the point they completely occlude their airway. Don't look in their mouth. Don't put anything in their mouth. If they don't like oxygen, then don't put oxygen on them. But this can be a life-threatening event for these kids, so you need to make sure you get to the hospital quickly. All right, we talked about rashes a minute ago. We were talking about assessing a kid and see if there's a rash on their chest. Well, rashes can spread with meningitis. It can spread all the way down to the feet and so forth. These little pin dots that you see here, that's a rash called petechiae. You see how they're starting to get bigger on this leg right here? When they start to get bigger, then that's basically petechiae gone wild, and we call that purpura, P-U-R-P-U-R-A. If you see purpura or petechiae on the legs like this, they probably have a raging case of meningitis, so you need to be very, very aware of that. They're probably going to have a headache and a stiff neck. They also can have bulging fontanelles in your infants. And again, if there's no other explanation for this rash, and especially if all of these are existing, then you better plan on them having meningitis. Fever can come along with ear infections, chickenpox, mono, pneumonia, epiglottitis, meningitis. We want to try to cool them without making them hypothermic or without causing them to shiver. So, cold packs or cool packs. Ask mom if she's been trying to give the child any kind of Tylenol or Motrin to reduce the fever. A lot of times, however, just tepid water from the tap is enough to start cooling these folks off. Make sure they realize that some of these kids, usually they'll outgrow this by the time they're age 5, but some kids do have seizures due to that temperature getting up to the point so quickly. We don't do rectal temps now. Most of us are either doing the temporal scans or we're doing oral temperatures. So if they are febrile, remove their clothing, again, the tepid water, and go ahead and transport. Kids can have seizures just like adults can. It's just a lightning storm going off in their brain. Infants, it can be very subtle. They may have an abnormal gaze. Their eyes may roll in the back of their head. They may create a sucking sound, or they may have some bicycling motions. The older they are, the more likely you're going to see the muscle contractions and the stiffness. So as we talked in medical emergencies, you can have status epilepticus as well. This is where you have one seizure that follows another without a period of consciousness in between, or if you have a one seizure that lasts at least 30 minutes. This is the tonic phase where they get very stiff, and then this is the clonic where they start to do the muscle jerking. So here's some causes of seizures. Some of these are a little bit more easily figured out on our part than others. A lot of them are this guy right here, though. The word idiopathic means it's an unknown cause. So a kid had a seizure. They couldn't find any of these things existing in that kid. So they just say the kid has an idiopathic seizure. So what do we do for these kids? Establish an airway if best you can. Again, with these kids as with the adults, make sure they don't hurt themselves, but also make sure you don't restrain them to keep them from hurting themselves, because they can break their own limbs if you restrain them too hard. The same things that can cause altered mental status in adults are the same things that can cause altered mental status in kiddos. Kids are very curious. They get into things that here's a great parent that's got all the chemicals underneath the cabinet where the kid can get a hold of them. Obviously, there's no childproofing on this cabinet. So you need to make sure you contact poison control as well as medical control. We talked during poisons that if it's one of these guys down here, the first thing poison control is going to want to know is what the active ingredient is, and the first name you see after the active ingredient, that's what they're really looking for. Take these to the hospital. Assume that they took everything. Okay, take them all to the hospital and let them know that the kid may have taken all of these. Always err on the side of precaution. Diarrhea and vomiting is very common. Kids can get tummy bugs. They really don't have a very good immune system developed yet, so they're prone to getting bacteria and so forth, viruses. This can cause them to become dehydrated, and that can certainly be life-threatening for kids. This is something I hope you never go out on. It's horrible when you do have to go out on this, but sudden infant death syndrome is a death in a child of less than age 1. And the medical examiner is the one that determines it's a SIDS death. He does the autopsy and he can't find anything as the cause of death. Then they typically will call it a sudden infant death syndrome. Mom and dad are going to be beside themselves. They're going to be guilt-ridden. They're going to think, if I'd have gotten up an hour earlier like I always do for that 2 a.m. feeding, instead of sleeping until 3, then the child would have been okay. That may or may not be the case. But years ago, back in 1957 when I was born, we didn't have all the fancy stuff that goes in cribs like kids do now. I had a wooden crib with a mattress with a piece of plastic around it and a sheet, and that was basically it. So a lot of times moms and dads would put babies down on their back, and so there were some instances of SIDS death, and so they were thinking that maybe when your child is on their back, when they vomit during the night on their back, they aspirate the vomit, and that is the cause of the sudden death. So then we went to, okay, let's put the kid on the belly in a prone position, and we'll see if we have a decreased instance of SIDS deaths. Well, about that time, we had all the fancy stuff that goes in cribs, the goose down comforters and the pillow top mattresses and all that. And so the kids were basically suffocating. They'd get, some of the linen or pillows, whatever, up around their nose. They'd suffocate, and that would be the cause of death. So several years ago, American Heart came out with a public service announcement that they say put your baby back to bed, meaning that you put the baby on the back when you put them down. The incidence of SIDS death has decreased since that has come out. So at least the thought is putting kids prone in a crib was one of the causes of SIDS deaths. In the United States, injuries kill more children and infants than any other cause of death. Remember, kids are curious. They don't understand the consequences that they may have for their actions. Kids do like to climb, so you're probably going to see plenty of falls from height. Think about head and neck injuries, but also, if they're lucky enough that they fall and land on their legs, broken legs, broken arms, and so forth. Diving into shallow water, head and neck injuries, sports injuries. Seems that kids are getting into even contact sports younger and younger. I wasn't allowed to get into contact football until I was in 4th grade. I know kids now in 1st grade are in full contact football. So, and then always keep your suspicions high on child abuse. Because the kids are top heavy, then head injuries are pretty common in kids for blunt trauma. They can result in respiratory arrest. They're probably going to have some altered mental status, and it can cause some vomiting and diarrhea as well. Other types of injuries, chest injuries, the ribs are less rigid and a lot more pliable. So the lungs are probably going, and the abdominal organs that are underneath the ribs are probably going to be a lot more likely to be injured. The abdomen is more commonly injured in children than adults because, first off, it's bigger in relationship to their size. It's a lot less protected. The air in the stomach can cause gastric distension and impede their breathing to the point that they can't breathe anymore just because of all the air that's in their belly. Burn trauma, kids are fascinated with fire, at least until it burns them. So we're going to do the rules of 9 or the rule of palms. And again, guys, we'll save that till we get to trauma on how to figure that out. All burns now are covered with dry dressings regardless of the extent of the burn. We used to use moist dressings on smaller burns, but it's going to be dry on all burns now. Stabilizer C-spine, make sure that you open their airway. Now, not all trauma deals with the neck and back. If they broke their foot, and there's no C-spine precautions that need to be made, if you need to open their airway, you certainly can do a head tilt chin lift. Suction and ventilate if needed, high concentration oxygen, whether it be blow by or mask on the face, keep them from getting cold, and transport. Now with abuse is improper or excessive action so as to injure or cause harm, whereas neglect is giving insufficient attention or respect to someone who has a claim to that attention. So probably the first thing you're thinking of with abuse is physical abuse, but and rightfully so, because you can see the signs at least of physical abuse. But the emotional abuse, the sexual abuse, those can be just as damaging to kids as the physical abuse. Neglect, there's different types of neglect. You can have neglect where the child is not getting the necessities of life, food, shelter, and clothing. It could be that they're a rich family, they have all of that and more, yet the parents are completely neglecting the children. They're having the nanny raise the kid or whatever. So there can be different types of neglect. So some signs of physical abuse, at least, look for bruises on the back, the legs, and the arms in different stages of healing. Now, guys, I want you to keep your suspicions high. However, if you have children yourself, we'll say school age or younger, if they're in any kind of contact sport, I mean, even soccer, you're probably going to have bruises on the legs from inadvertently being kicked, or even if your kid's not in sports like that, your kid just goes to the playground or goes out in the backyard on the swing set, there's probably going to be bruises on the arms and the legs, and that's pretty typical for a kid. And yes, there could be in different stages of healing, but bruises on the back or the torso or the buttocks, that's usually abuse if you see bruises in those areas. There's multiple fractures that are in various stages of healing, or if you see an arm that's crooked, the other arm straight, there's probably been some abuse, and they never took the child to the hospital to get that broken arm checked out. Closed head injuries from the shaken baby syndrome, abdominal injuries from being punched or kicked. Genitalia injuries, they can be either lacerated or the skin can be avulsed or pulled away. Bite marks from adults. Now, if you've got a 2-year-old biting another 2-year-old at daycare, I don't know that I would call that child abuse. Look for fresh burns. The glove or the stocking burns, that's where they'll dunk their feet or their hands into hot water, and you'll see a very distinct line of demarcation where they went in just to the wrist, and you'll see a very distinct line between red and not red where they stopped the immersion into the hot water. Some adults like to throw their lit cigarettes at their kids, or they'll bring their kid over and put their cigarette out on them. If you've got a really inconsistent history, like they say, oh, he's just a kid that falls down a lot. Kid falls up the stairs. Well, kids don't fall up the stairs. Also, keep an eye out on this. A lot of times, especially if they're serial abusers and have gotten away with it, the parents usually have their story already thought out. So when the police get there, they'll separate the parents, and one will take one parent in one room, one will take one in the other room. They'll get their stories, and then the police will usually switch and see if they get the same story that the first officer did. They usually have their stories figured out. Also, if they do keep the parents together, or the police are not there yet and the parents are there together, and you notice that dad's the only one doing the answering, even though you're asking mom questions, dad's doing the answering, and that may be a sign to keep your suspicions high. So you do have a legal responsibility to report child abuse if you suspect it. If you suspect it and it ends up not being child abuse, then they can't come after you for slander or libel or defamation of character. However, if you choose to not report it, then that's an offense you're going to have to face. So always side on the error of caution with these kids. So the shaken baby syndrome, they just pick the kids up by the upper arms and they just shake the kid, trying to get it to quit crying. Eventually, if they do that long enough, the child will quit crying. So this is going to cause the fontanelles to bulge because of the increased intracranial pressure. They're going to have some type of altered mental status, or they're going to be unresponsive. And they have what's called a disconjugate gaze. If you have a conjugate gaze, that is normal, but a disconjugate gaze is where the eyes are looking in two different directions at the same time. So whenever you turn a child's head from one side to the other and the eyes don't follow in the same direction, then that's a disconjugate gaze. All right, so some clues of abuse and neglect. Does the parent seem inappropriately unconcerned? Is dad still sitting over there drinking a beer, watching TV while you're assessing this child that looks like he has a broken arm or some cigarette burns on him or whatever? Do the caregivers have trouble controlling their anger? Do you get the feeling that at some point right now that the parent may explode? Do the adults appear depressed? Are there any indications of alcohol or drug abuse? And do the adults speak of suicide? So other family members tend to lie. Like you may ask Mom, is there any abuse going on here? Oh, absolutely not. Well, she knows good and well that her husband is abusing this child on a regular basis, but she has probably been told by her husband, if you let anybody know about this, then you're going to get yours too. So a lot of times parents will cover for their significant other. That's not very parental, but sometimes that's what happens because they're living in fear. Now, if you have a sexually abused child, don't let them use the restroom. Don't let them change clothes. Don't let them bathe, just like with the adults. Make sure that you do not accuse anyone in the field of abuse, whether it be child abuse or adult or elderly abuse. Don't ever accuse them in the field. That's not your job. They need to go to a hospital that has what is called a SANE nurse, an SANE. That's a sexually assault nurse examiner. Used to, Parkland was the only one you were able to go to, but more and more hospitals are getting SANE nurses that can do the exam upon arrival at the hospital. So just in the back of your protocol or somewhere in your ambulance, there should be a hospital capability form that you can look at, and it will tell you which hospitals in Dallas County have SANE nurses available. So it is, you do have to report this. You typically are going to report this to the police. You typically don't pick the phone up and call CPS and get a hold of them. You typically are going to tell the police. Now, let's say that you go out to a house and this child is beat within an inch of his life. The parents let you take the child. The police are not there yet. You don't care if the police are there yet because you got to get this kid to the hospital. You get to the hospital. Make sure when you are en route, you let dispatch know that you need police to meet you at the hospital. You don't have to tell them why. Just say, I need police to meet me at the hospital. Tell the hospital staff when you get there what your suspicions are. And then when the police get there, you need to tell the police as well. And just remember, guys, you are the only ones that saw this scene. A lot of times these scenes can be cleaned up because the police can't go to this house. If you are in the house and the police show up, the police have every right to go into that house. But if they're not there and you tell them at the hospital, and then they go back to the house and knock on the door and say police, they're going to say, you got to have a warrant. It's going to take a while to get a warrant. In the meantime, they've cleaned all the cocaine up. They've hidden their clandestine drug lab. They've taken everything and they have gotten rid of it. So you need to make sure that you paint a very, very good picture of the scene to not only the hospital staff, but the police as well. All right, we talked a little bit about this the other day. I think this is the same slide we saw the other day. I do apologize for that. But there's not a whole lot you can do as EMTs for kids with special needs. Like we talked about the other day, do not be afraid to let mom and dad do your job for you. They're a lot more comfortable with it than you are. So again, just let the people that take care of these kids every single day, they can certainly take care of the kid in the back of the ambulance. You're there to assist them, and that's certainly okay to do that. All right, so that finishes these 3 chapters. Again, I do want to apologize. I do think I had the chapter numbers wrong, but I do have the subject matter correct. So until we meet again, thank you very much.